what's the role of government in trying to address health issues in poor countries? There are a number of different conceptual frameworks you could bring to that. And I think they each have value. So let me start with a very neoclassical economics model, very sort of Chicago economics model approach, which is health investment is human capital investment. There are rational individuals, rational households deciding when to invest in health. They invest if the gains exceed the costs. And under that, there'd be only a very limited, there'd be a very specific set of cases in which government intervention would be warranted. And I'll talk about some of those later on. Another perspective is provided by behavioral economics. Behavioral economics emphasizes common departures from rationality, or at least simple models of rationality. And a lot of that draws on insights from psychology. The policy implications are something that's still being worked out and debated. But if people are making systematic mistakes, maybe there's a role for the government to step in. If we take it a step further and think about cost-effectiveness analysis, as it's often conducted in a lot of, really outside the US very widely, governments don't think about, well, individuals are optimizing, is there a particular market failure, an externality, or asymmetric information that justifies governments coming in. They just say, well, let's look at the benefits of this, of the health investment, the costs. And the health planners in the government would say, do the benefits exceed the costs, from letting the government calculate that. Not saying we're assuming that individuals are calculating that correctly unless there's some reason to think there's a gap between the individual incentives and the social incentives, like externalities due to prevention of infectious disease. So this would be very widespread in the UK, for example. It's not a very popular approach among, at least in the US academic world, but it is in the policy world. And I'll argue that there's, in fact, that should be an important, this has an important role to play. Let me put something that, at least for economists like myself, is even more alien, which is thinking about things from a human rights perspective. And I'll come back to that at the end, but I'll actually argue that is also an important perspective to have. And then, again, at the end, I'll talk a little bit about political economy. Okay. So what I'd like to do, there's now been a lot of, it's been 15 or 20 years since the recent wave of randomized evaluations in development economics. I did some work initially in Kenya, there's the Progressa conditional cash transfer program in Mexico. Since then, there have literally been hundreds of studies. Not all of them complete, but many of them complete or yielding results. And I think it's worth stepping back and looking at the results of those studies. Let me just come back a second. And seeing if there are any general lessons that we can draw. And what I'll focus on today, there are some, I do have thought about the implications for models of health behavior, but I'd like to focus on the policy lessons. But to even figure out what the policy implications are, you can find that usage of bed nets goes up 10% if you do something, but is that good or bad? You need to filter them through some sort of analytic framework, and that's why I've put these conceptual frameworks up here as well. Okay. So, to say broadly how I'd like to divide things up. There are two broad divisions. Sorry, I'll say one more thing on this to go back to this slide. In addition to the conceptual framework, let me draw a distinction between two types of health improvement. The first type of health improvement is when you're just trying to get those basic technologies, those basic prevention technologies like vaccination, like clean water, like mosquito nets against malaria. Those are things that can be applied to pretty much everybody should have them. You don't need to have a health system that's delivering individual diagnoses to people. I'll argue that's the low-hanging fruit. So getting to a level of life expectancy like Vietnam's is to some extent, or maybe a bit lower than that, is the low-hanging fruit. Taking it to the next level, and saying, and that's going to increasingly be the challenge as the burden of communicable disease goes down. As economic development occurs, the challenge of the future is going to be delivering healthcare services. That's a much harder challenge. So that's what I'm going to distinguish that in the talk. And thanks to Mead for emphasizing in earlier an earlier drafts of this emphasizing the importance of that distinction. Okay, so first half of the talk, I'm going to talk about consumer behavior with an emphasis on what's really the low-hanging fruit of some of that prevention behavior, a lot of things on communicable disease. Talk a lot about the role of price, what's the impact of charging, say, for mosquito nets or for clean water. Talk about the impact of convenience, incentives. I'm not going to focus on the sort of academic testing of a model and implications for behavioral economics, but I'll try and say a little bit about it. Then talk about if we're starting to learn some lessons from this, how can we apply them? And I'll give an example of something that I've been involved in, which is safe water. Okay. Then the next half of this, I'm going to turn to what's the much more difficult problem of healthcare systems, where it's not simply a matter of mass prevention but requires diagnosis. So I'll say a little bit about the consumer behavior side on that, but I'll focus on the core of the problem, which is provider behavior. And that, say a bit about the background, illustrating what a tough problem it is, how weak healthcare provision systems are, both the public provision and the private provision. And then talk about several, I think, promising experiments to try and deal with it. But I think this is an area where a lot more evidence is known, where we know a lot less. Okay. So let me start on the prevention side and talk about a big sort of classic debate in policy, which is on user fees and charging. So, there had been quite widespread support for user fees. And that, I think, came from several sources. First, economists' sort of normal presumption that individuals should be faced with the cost of what they do, and then they'll weigh up the costs and benefits accordingly, very much coming from a human capital model. It's also a fact, which is that the poor are paying for services. They're paying a lot for healthcare, for water. It's the idea that if you charge, you might screen out the things that are low valuation and only remain with the things that are high valuation, so it can be efficient. There's some theories, this didn't come so much from economics, but was very important with policymakers, which is there's psychological cost of pain. That's a typo. Psychological impact of pain, I should say. There's a view that if you don't pay for something, you're not going to value it. So many NGOs, many government officials many practitioners feel that very strongly. Then there's another issue, which I'm not going to deal with in this part of the talk about consumer behavior. But there's a view that if consumers are paying, then that will affect the way providers behave. And if consumers aren't behaving well, providers aren't going to behave well. If consumers aren't paying, providers won't behave well. But the critics of this often came from a rights approach, talking about the impact of fees on access. It's often a compromise, which is, okay, we'll have fees, but they're going to be very small fees, and then we'll have a system of exempting the poor. Okay. I think this is an issue where randomized evaluations have been able to shed a lot of light. And where I think a fairly consistent picture has emerged in a wide variety of settings. So let me first talk about two cases where there's where under the simplest, sort of the most conservative of these approaches, the human capital model, there would be a case for public subsidies. And those two cases are, first, where there are externalities. So if infectious disease is in the poorest countries, and I'll be focusing on low-income countries rather than middle-income countries, infectious disease is about a third of the disease burden, and a greater share of the differential disease burden from the developed world. In those cases, if I protect myself from a disease through vaccination, I don't just protect myself, I may be protecting the entire community. And the same thing may be true for mosquito nets and so on. So there may be externalities from that. Second case is, if there's infrastructure which has a high fixed cost and a low marginal cost or zero marginal cost of access, there may be a case for subsidies. But that's a theoretical case. There are a lot of questions that would arise in practice. One of them is, what's the quantitative magnitude of this? And so here's a case on externalities. So this is school-based deworming in Kenya. Diesel Okay, that should be disease. Externalities on neighboring schools. So this was a randomized, there's actually rank ordered, but rank order assignment. Trial of deworming in Kenyan schools. Some of the schools were treated in the first year, others were treated second year, others after that. If you look at the neighboring schools to the schools that were treated, so you go partway through, the schools, not only did you see health improvements in the schools that were treated, but you also saw improvements in the schools next to those schools, nearby, within a few kilometers of them. You also saw there were some, at the time, deworming's now been shown to be safe even for pregnant women, but at the time there was uncertainty about that. So girls over 13 weren't treated, yet you still saw improvements in that population as well. You both saw disease prevalence going down, and you saw school attendance going up. Again, this is both in the treatment group and in the people who weren't treated but were in sort of epidemiological range of them. Then Owen Ogier, the World Bank, has a paper showing cognitive gains for younger children. So this suggests that the externalities were quite substantial. These are sort of classic disease externalities, and we made some attempt in the paper to say, well, would the benefit of those externalities justify subsidizing it? And we argued that they would. And we're now working on a new paper, which I presented here a few months ago, looking at what I don't think I realized at the time, but have realized since, is actually another form of externality. So we're now following up these kids who were in the original study as young adults, so they're in their 20s. And we see big increases in labor supply. People are working more hours every week. That's, I think, a result that I presented when I was here. When I was presenting the seminar elsewhere, someday I wanted to do a public finance analysis with a deadweight loss in there. Somebody pointed out to me that this was not exactly right for an expenditure that increases labor supply. And I sort of thought about it for a while, talked to them afterwards. So it turns out, the Laffer curve, okay, it doesn't have a great reputation, but the idea of a Laffer curve is that you can, in some cases, at least theoretically, you could have a tax cut that could actually increase revenue. What you have in this case, it looks like, and we're still working on this, is the expenditure equivalent of a Laffer curve. So if you make this expenditure on deworming, the labor supply increases, and even at Kenya's moderate tax rates, the increased labor supply means that the net present value of increased tax revenue is likely to exceed the cost of the initial expenditure. In other words, Kenya could lower its VAT tax rate if it put in this program. It could have a lower tax rate with it than without it. Okay? So that's actually a fiscal externality. When the people are who are dewormed, they're creating a positive externality for other people through their tax revenue that they'll generate. Okay, so that suggests these externalities, at least in this case, are substantial.
But the individual himself has the increased labor supply.
Right. So
it's not. Why is it external?
Oh, so if imagine I earn $100 more, I'll keep 85 of those dollars. 15 of those dollars will go back will go to the treasury because I'll be paying taxes, VAT and other taxes. And so that turns out that $15 is enough to pay for the program. The net present value of just the taxes on the increased labor supply, not the entire. Obviously, the part that I keep is not an externality. Okay. Of course, would these taxes, would these external, even if there were externalities, if the $85 is enough if the increased earnings, and we find quite substantial increases, if that, you might think, well, that should alone be enough to motivate the individual. So then, why do you even need to subsidize this? Okay. What we found was that, in fact, empirically, despite these huge benefits, there was very high sensitivity to prices. I'll say more about this in other contexts later, but while I'm on deworming. So it was quite small fee for this. The NGO, like many NGOs, felt in principle they wanted to charge something. So they had this compromise of, well, we won't charge the full cost, we'll charge just a very small amount, because almost as a matter of principle. we were able to persuade them to at least have a subgroup that didn't get charged, and that's why we were able to get these, to measure the impact. What we saw was 80% lower take-up once they put on the fee. Okay. Now, there was not that much, they had some, because of the way the formula for the fee worked, there was some variation in the fee per child. That didn't seem, it's not as cleanly identified, but that didn't seem to have that much impact on take-up. So, but it was just going from no fee to a fee had a big impact on take-up. I'd argue that certainly in this case, and I think in other cases as well, this compromise that comes out of the conflict between people who say we should charge for things and people who say, but you can't charge too much or you'd be impeding access. And so the compromise of a small fee is actually the worst of all possible worlds. It's the worst of all possible worlds because you really cut participation a lot, but you don't raise much revenue. And in this case, it was probably, arguably, you raised less revenue than the administrative costs. And it didn't look like this targeted things effectively to the 6 students.
Before you go on, Mike,
yeah.
Could you explain the picture?
Yeah. So I'll be honest, which is I didn't select these pictures, and so I'm not 100% sure if that all the pictures match the slides, including this one. I hope that this is a picture of, so this is school-based deworming. So teachers can administer the deworming pills, which is administratively very, kids go to school, most kids go to school, and kids who aren't in school can come. So I'm guessing that this is a deworming session at a school. I mean, these are kids in their school uniforms, and that's a teacher, but it's possible this is just a random picture pulled off the web that has nothing to do with deworming, to be honest. Okay. Okay. So let me take another case that's within a very standard human capital neoclassical economics framework, why subsidies might be justified, or a case where they might be justified. And that's in the case of public goods. So give the example of water supply here. So in rural Kenya, a lot of people collect water from springs. So imagine that there's just water, sort of water bubbling up from the ground in the middle of this field. Okay? That water can be easily contaminated by runoff. One approach to addressing this problem is to protect the spring. So here you see a protected spring, and this really is a protected spring. So that there's a pipe that goes down to what's called the eye of the spring, and the water comes out, and there's concrete around it. It makes the water substantially cleaner. It costs about $1,000 to do that. The marginal cost is zero. This is a spring. The water is flowing out. If somebody isn't collecting water here, the water is just going to go off into the field. So technically it meets the definition of an excludable public good, I would say. Okay? So I'll come back to the implications of this in a second. There was an NGO that came through and protected a bunch of the springs. They put in the pipes and the concrete. Fecal contamination fell about 2/3 at the source, although there was some recontamination of the stored water in the home, so the improvement at home wasn't as big. There's a 25% reduction in child diarrhea. Okay, so that's the sort of straight results from the randomized evaluation that we can be most confident of. But we decided we'd try and do something for those of you who are interested in such things. I think one of the trends in the literature is to try and combine randomized evaluations, which give clean measurement of causal impact, with more structural models so that you can get at a wider set of questions. So if I was a health guy, I think we'd sort of stop here. Okay? Not just because that's where the health results end, but because they're more conservative about the claims they want to make. So, but if we're willing to impose some more assumptions, you can use a travel cost model to see, are people willing to walk farther? People have lots of water sources in the area. They can go to a stream, a lake, they can go, maybe there's a well somewhere else. Which one doesn't? There's maybe an unprotected spring somewhere else. Were people willing to walk further? Well, it turns out they were, but not very much. So you can use the extent to which people switch their water sources to estimate how much they value the increased cleanliness of water. One nice thing about this is it just makes the water cleaner. It's no more convenient. It's still at the same place it was before. So you're getting an estimate of willingness to pay for cleaner water. okay, with various assumptions, assuming people understand what's going on and a bunch of other things. Okay. If you know how much people value this, and let's say we're following the standard rules of economics. The society should value this exactly as much as a household does. Let's imagine there's no health externalities from cleaner water. Maybe there are, but let's say we don't want to count on that. Well, it makes sense for society to invest in cleaning up this site if the sum value of all of the beneficiaries of this exceeds the $1,000 it costs to install it, or let's say $1,500 if you include the cost of maintenance. It turns out that you can figure out a cutoff. If enough people are in the neighborhood, then it's worth doing it. If not enough people are, it's not. Okay. If you look at this from a point of view of a health planner, and you say, how many cases of diarrhea do we think are going to be averted? How many DALYs are saved? Turns out they would invest. They'd be much more likely to invest. They would invest down to, even if they're only just a small number of users. So one thing, again, we're finding apparently low valuation on health. So that's, I'll come back to that later. But the direction I want to take this in now is, in this case where there's a very high fixed cost of investment, and then something can be made available at pretty much zero cost thereafter, you're not in the totally standard case of neoclassical economics. You're in a case where the welfare theorems that say that free markets work well don't apply. It's very much like the case of intellectual property. If somebody can download things for free from the web, there's a static distortion in not letting them download that. Okay? On the other hand, because it's zero marginal cost to society for somebody to get that free water, so preventing them is inefficient, but on the other hand, it generates a benefit. It could generate a dynamic benefit, which is that most of these springs aren't protected right now. Why are they not protected? Private landowners don't have an incentive to protect them. They're expected to make water available to their neighbors, both culturally and, in fact, Kenyan law recognizes these norms. So you can't just install this and start charging. You could ask, what would be the impact of private property rights? So on the one hand, you'd get some static distortions. Some people for whom this is the closest source or the cleaner source would not use this. Instead, they'd walk off to a stream somewhere and collect there, getting dirtier water, maybe walking further. On the other hand, it turns out that those static distortions are quite large when we model this. Again, this involves additional assumptions. That the dynamic benefits of private property rights, the extra incentives to create springs, are not very big in our context, when based on our estimates of willingness to pay. Not that many landowners would actually find it profitable to put in springs, even if they had private property rights. So it turns out in this case, when we simulate this, private property rights would not actually do very well, and you're much better off if there was some sort of, if the government just paid to do this, or if it had a voucher system to encourage private landowners to do it. That's assuming somehow that the government could work out all the problems administratively in making that happen without corruption and so on. So that's a huge, huge challenge. Okay. Okay. So these are two. I see that these weren't on my slide. Apologies for that. These are two examples where even under the simplest human capital model, government intervention would be justified. What I'd like to talk about now is some evidence on what happens if we're setting aside those issues of externalities of public goods. Is it the case, we got some clue in these two examples, that individuals seem to place remarkably low, if you think about this in terms of the human capital model, and you say people's actions reflect their valuation, you're sort of driven to this conclusion that people put pretty low value on health. So let me look at some evidence in terms of prices and preventative activities in particular, and see if, talk about the extent to which this holds up. Okay? So this is a slide from JPAL. This is looking at a variety of contexts. So I put up the bed nets I put up the deworming example, but you can see it comes up case after case after case. These are all prices that are actually extremely subsidized. So the bed nets example, it's sort of, are you talking about 90% subsidy or 95% subsidy? And in all of these cases, there's a lot of responsiveness of demand to price. Okay? So the human capital model would say that there should be responsiveness of demand to price, but it wouldn't. What seems extreme here is there are so many cases where moving from a relatively low price to zero price is having a very big impact on demand. Okay? And that, would be a little bit of a coincidence if for all these different, you might think that at some products, the inconvenience would be so high that you would never use it even with a big subsidy, or other cases you would want to use it even with a relatively high price. There's a lot of things where being right around zero, moving from a positive price to a zero price seems to have a big impact. Okay? So it looks like one of the issues in the debate was maybe price doesn't affect take-up that much. It looks like it does. Another issue is, does pricing better target products? Do you get products to the people who need them the most? So I mentioned earlier, no evidence that the children who had a high parasitic worm load were the most likely to pay for deworming. It doesn't look like the parents, remember, this is a school-wide program. If you have to pay for it, some of the kids in the school have worms, some don't. You might think that the parents would pay for it for the kids who had worms and not for the ones who don't. There wasn't any evidence that was the case. Similar study on nets. There's no evidence that anemic women are more likely to purchase a bed net. We looked at willingness to pay for small bottles of chlorine for water treatment. So diarrhea is dirty water. The main way that's going to kill somebody is through diarrhea. Most adults are not going to die unless their immune system is compromised. They're not going to die from this. They already have antibodies in their system to what they're going to get from the local water supply. People are most likely to die are young kids. Okay? So you might think that the more young kids a household had in the family, the more they'd be willing to pay for a small bottle of chlorine. There's no evidence that that's the case. Okay? So all of these things are a little bit, I don't want to claim they're definitive evidence against the idea that households are maximizing, but it's one more piece of evidence that doesn't seem to fit so naturally with the standard economics model. Now there is some evidence that in the case of chlorine, that the people who are more likely to treat their water with chlorine are more likely to pay for it. So this is a study in Zambia. They found some people got the chlorine, and if they were charged a lower price, they're more likely to take it and then not use it for that. And we could discuss that further, but I did want to put that caveat. What about the idea that this idea that doesn't really come from economics, but is quite strongly held by policymakers and perhaps with strong foundation in psychology, which is that by charging something, you get people to value it and they're more likely to use it. So there's a couple of cases where studies that have looked at that. So, three in particular. So there's studies in Uganda and in Kenya that looked at usage rates, which is not perfectly measured, but between people who received bed nets for free and people who purchased it. And so the people randomly assigned to a group that got them for free, another group had to purchase it, and they compared, is the net hung, and other indicators of whether it's being used. They didn't see any difference in usage rates. That's not to say that everybody uses their nets. Some people don't, but there was no difference. Whether you had to pay for this didn't seem to affect whether you used it. Similar results in Zambia with chlorine. Okay. One might ask another question, which is, okay, maybe in the short run you don't get an effect like this, but maybe if we give something away free now, it's going to be very hard to get people to pay for it later. So that's at least one theoretical possibility. That's the price anchoring story. Another possibility is that if you get something for free now, you learn about it, you learn that it's good to use or easy to use, and you're more likely to pay for it. It's a study in Kenya, and by the way, I'm not, for space reasons, I'm not putting up the authors of all of these studies, which I apologize for, but it's available. I'm happy to share documents, which will have all these references. So in a study in Kenya, individuals were offered bed nets at different prices, and then they went back a year later and offered to sell them a second bed net at a fixed price. Take-up was higher for the people who received the first net for free. So maybe there was some price anchoring going on, but at least in the case of nets, that was outweighed by the learning effect, the free sample effect. Okay. Similar results with chlorine. Okay. So one thing I want to point out is there's a lot of different studies here in different contexts, and they seem to be, and I'm not going to necessarily argue that this would be the same on the producer side, but on the consumer behavior side, there's much more, empirically there seems to be some patterns that seem to hold quite often. I'm sure that people will eventually find exceptions, but it's surprising in a way how much commonality there is across different geographies and different products. Okay. Here's an interest. One can ask what's going on here. Why is it that demand is so sensitive to small prices? So one potential answer, and I think it's part of the answer, is liquidity constraints. Maybe at any given moment people don't have a lot of cash on hand, so even asking for a small amount of cash means that they can't do it. So here's a study on nets where people were given 3 months to gather up the money. And you'll see that there was much less responsiveness to price in that case. So I think that's part of the puzzle. My own view is that that's not the entire puzzle. I think there's also some important behavioral factors going on here. And I can talk more, maybe I'll talk more about that later, but one thing that I guess sheds light on that is looking at the impact of not price, where you may or may not have cash on hand, but convenience and distance on take-up. There's a few studies that looked at the impact of distance on take-up of preventative products. I wouldn't say these are all preventative, but I think they share characteristics of preventative devices. One is picking up HIV test results. So this is a result that I think is quite dramatic. So this was, you could think of all sorts of reasons why people don't want to know about their HIV status. Stigma, how are you going to deal with this knowledge? You can think of reasons why people would want to know their HIV status. Those both seem like very strong forces, either to know or not know. You wouldn't think that a small factor like, are you 2 kilometers away or 1 kilometer away, would make that much, from the place where you're going to pick up your results, would make that much difference. But it turns out it does. So this, in this study, Rebecca Thornton was the person who did this. She randomized the location of where people would pick up their HIV results. These are from, the whole set of people had already gotten the HIV test, and it was just, were they going to pick up the results? It turns out a lot of people take HIV tests and don't pick up the results. That was actually quite influenced by distance. Iron fortification. The distance to whether you're near a miller who will fortify or not is the big determinant of whether you're going to get your grain fortified. Water in Kenya, I mentioned that earlier, the distance makes a big difference. Here's an example which is also striking in another way, which is we looked at providing coupons for picking up chlorine treatment for water versus people who had it brought to their house. So initially the coupons were redeemed. These were coupons that allowed you to get free treatment. So people are going to the store to shop anyway. The stores would redeem the coupons and give you a bottle of the WaterGuard is the brand name in Kenya of the water treatment. Initially, people redeemed at a high rate, but as months went by, even though they had a supply of coupons, they stopped redeeming them. So a small amount of convenience, in this case, it wasn't the convenience of walking further. You're probably going to the store pretty often. You only need a new bottle of WaterGuard every month. It was just remembering to get the coupon out. Okay, so for me, this makes total sense. I'm not very good at redeeming coupons, but it looks like I'm not the only one who behaves that way, I guess. Okay, so if you got the bottle delivered to your house, you're much more likely to use it. Okay, so so far I've talked about reducing barriers. You could take this a step further and you could say we're actually going to pay people to get treated. And if you look at the benefits from some of these things that have big externalities, it looks like there's a case for that. The benefits of of deworming or vaccination, or I think would be big enough to the externality benefits would be big enough to justify that. I'm not saying that was the motive in these particular programs. So the classic example of this is conditional cash transfers. So in Mexico, they provided quite large fractions of income to poor families if they would get basic education and preventive health care. And visits to public clinics increased a lot. Children were less likely to be reported ill. This should actually get some more. I believe there were height gains as well. I mean, quite, it looked very good. So a recent paper on Malawi, which compares these conditional cash transfers, where you had to do the behavior to get paid, to just a straight unconditional cash transfer. This was for teenage girls. So the conditional cash transfer kept the girls in school. The unconditional cash transfer was more effective in reducing teenage pregnancy and marriage rates. So what turns out to be the case, and this is a bit surprising, it's in some ways the mirror image on the result on pricing, is that you don't actually need to have these very large fractions of income to incentivize a lot of behaviors. So even pretty small incentives can be enough. So I mentioned the HIV test, picking up HIV tests in Malawi on the distance. They also tried paying people a small amount, between $0 and $3. Turns out any cash voucher led you to be twice as likely to obtain the HIV test as no payment for it. Immunization in India. And you hear about, that's a big priority for global health. You hear about cases people don't want to get immunized because of religious beliefs or other beliefs. They tried two things, regular immunization camps and then adding a small incentive, a kilogram of lentils. They got 39% full immunization with the incentives in the camps. This was an area with very low immunization rates, or full immunization rates of getting all 3 shots. 18% in the camps without the incentives, only 6% without the camps. Yeah. Mm-hmm.
I've looked at the Thornton data, and one of the things when you're looking at the impact is that even though there's an increased significant probability of getting your test results, there's no increase in the probability that they use those vouchers to then, or any money to use condoms.
Right.
So then the health impact is...
Right. So I think that's one thing you have to think about in all these cases, and I'm glad you brought that up, and I'll come back to that in the case of the acute care, but which is, in each of these cases, showing that there's sensitivity of behavior to price is only part of the case for arguing something should be subsidized. It has to be effective as well. I think in the case of, take the extreme case, in the case of vaccines, we can be pretty sure of that. In the case of HIV, getting HIV results, yeah, I think there's plenty of room for debate, and I agree that I don't know what I would come down on in terms of if I were a policymaker and had to decide, but I agree that the evidence isn't clear that you can tell stories either way, and yeah.
It's complicated behavior.
It's complicated behavior, exactly. As an academic, I don't have to decide what to do. I can just say something like that. The policymakers have to make some stand based on the available evidence. So, and I'll come back to that in a slide later on. We know these results seem to be quite consistent on take-up, but what are the policy implications? Okay. So, but just continuing with what do we know about the facts about behavior from these studies. Just more evidence that a small incentive makes a difference. In this case, the difference here was not on the margin of do you get the first immunization. It was on the third. So it wasn't you're getting people who don't believe in vaccination to get vaccinated. You're they think it's religiously wrong, but you're bribing them to do it. No. It's much more consistent. I'm not putting up these models, but with maybe that's the next slide. Yes, behavioral models. So I won't put up the models. But I think a lot of these results are very consistent with the model of present bias. So a model of present bias is something where standard economics assumes there's discounting, but assumes that discounting is relatively similar over time. I discount 10% a year from now, 20% 2 years from now, and so on. A lot of psychological evidence suggests people are motivated by the immediate present, and then they discount in the future, but they don't discount that heavily between different periods in the future. In other words, if there's a cookie right here, I would eat it right now, but I would, but because there's a present benefit and there's some long-run cost. But it's one of the implications of this present bias is that I myself might want to say, well, I don't want that cookie to be in front of me tomorrow or 6 months from now, because I don't value the consumption of myself tomorrow that highly relative to my lifetime, the rest of my lifetime. I just value the present high relative to the future as a whole. So people might want to lock themselves into situations where they're going to take behavior that's good for their health. We see that here, people trying to join exercise clubs, do other things to influence their health behavior. I think so in that type of a model, you can easily get procrastination effects. I want to take my kids to get vaccinated, but I'm really busy today. I'm not going to do it today. I'm going to do it the next day. People never get around to it. A small upfront benefit, like I'm going to get a kilogram of lentils today, can push somebody over the edge and help them do what they really want to do, what some other self inside their brain wants to happen. Okay? Another theory is this is a matter of overcoming decision costs, that processing this information is quite difficult. I have a section, which I'm going to spare you due to time limits, on evidence on how people respond to health information. I think that's an area where there's quite mixed evidence and we still have a lot to learn. But I think some of that evidence is consistent with the idea that there are decision costs, that if a problem's too complicated, people can't deal with it and sort of set it aside, and that salience is very important. That when health education is important, it's often by making something more salient as opposed to literally giving us more information. There are examples where I think the pure information is helpful as well. Okay. So, what are some policy implications of this? Well, key point is that demand for cost-effective preventive health products falls sharply with price. Having a small fee can often raises very little revenue, decreases demand significantly. Charging doesn't target people, but there are budget constraints. Okay? So how do you do things? Well, first is you probably want to target the most cost-effective things, and cost-effective presumes that it's effective for health. And in some cases, it may not be. Okay? So that's a clear thing to look at. I think there's value to the basic human capital model under which people make decisions based on private benefits, not social benefits. So if there are positive externalities, maybe it's worth subsidizing in those things. And some prevention, particularly for infectious disease, has that, less so for non-infectious disease. I think another category that's very important is something I haven't talked about much, but is intra-household distribution. Remember, there was not more demand for water treatment when there were more kids under 3 in the household or under 5 in the household. There's an intra-household distribution argument for subsidizing things that are going to, if society cares more about the kids, which I think it arguably does, where the kids are going to benefit, but the parents are going to have to pay. Making things as convenient as possible is going to be important. Okay, let me speed up a little bit, but what I'd like to talk about is how an example of how people are using these lessons that are coming out from randomized trials, from insights from behavioral economics, to design new approaches on health. So let me give the example of chlorination, which is something that I've been involved in. So that's safe. It's used in most pipe water systems in rich countries. It's effective. It kills germs. The chlorine residual protects against recontamination, which was a problem with the just putting in an infrastructure. So there's a bunch of randomized trials of this that have been done in the health literature. Reduces child diarrhea 20 to 40%. Some caveats to that, but I think that's the basic bottom line. And it's very inexpensive. But these small bottles of chlorine solution that are sold have pretty limited take-up. They're being socially marketed, they're being advertised, but most places it's 1 or 2% of people who are using it. Zambia, some other places have higher take-up, but most places it's pretty low. Okay. We know from some various studies there's a big impact of price on this. There's a big impact of, I haven't talked about information or health promotion, but promotion, personal contact seems to increase take-up, and convenience seems to increase take-up. So this is an approach that I've been involved with. These are sort of an old model of the dispenser, but at the water site, if you put a container of the chlorine solution, and then there's a tap here, and if you turn the handle, it releases the right amount for a jerry can of water. That approach achieves, first, it's cost saving, because chlorine's so cheap that those small bottles of chlorine that you buy, the plastic costs much more than the chlorine. Second, it's convenient because you don't have to go look for the bottle and measure something out. You're collecting water anyway, and you do it right then and there. So habit formation is another thing that's emphasized in the psychology literature. Having a set time each day, set time you brush your teeth, for example, this is the equivalent of it. The set time to do this is when you're collecting the water. And it also allows for social learning. It's salient. There's a visual reminder to do it. This allows for social learning because you can see other people. You can see other people do it. You can ask them questions. Other people can see whether you're doing it. So you can have a social norm for use up here. So when we looked at this, we found that you go from less than 10% take-up to the majority of households using this, and that seems to persist over time, even after the initial promotion period. This is being scaled up. Jeremy Hand, who's with the IPA, are you around, Jeremy? Yeah, Jeremy, who's I can tell. He's leading the effort on scale-up of this at IPA, but now 400,000 people in Kenya have access to this. One of the issues is how are you going to arrange financing of this? So I think this is a great example of something that should be provided for free, based on the results of the health impact results and the results of consumer demand studies, suggesting that you're going to get much higher take-up if it's free. But how do you finance that? So various bits of the Kenyan government have financed this to a small extent, but on a sort of pilot basis primarily, and other NGOs and so on have gotten it to 400,000 people. One possibility for this is actually carbon financing through carbon credit savings, and that's something that IPA is currently exploring. It's exploring it, not for it to do it necessarily, but just looking into the issue. Okay, so that's just how am I doing on time?
It's 1:20.
1:20. Okay.
Until 2.
Okay, I'll try and speed up. There's more to say on this. I think these are really important topics, but unfortunately there are fewer studies. Let me say a little bit. I think we know much less about what the remaining topics. Let me say a bit about. I focus very much on prevention. Let me say a little bit about acute treatment and insurance. Okay, so I think this is a case where your question definitely comes up, which is what's the health impact. So a bit of background is I think there's a strong case for thinking that there are going to be issues around acute care. Poor they often spend a considerable amount of money on health care, and they're subject to risks from health shocks. And there's some evidence that can have long-term impacts, not from randomized studies, but from other types of studies. People may, they may pull kids out of school, for example. Okay. What's the evidence on the price of treatment or on insurance? Well, Indonesia did an experiment where the government allowed some districts to charge higher fees. So the prices in those districts went up. They went up everywhere, but they went up more where they allowed it. What happened to health? Well, self-reported health actually got better in the areas that they allowed to raise the fees. Okay. Objective measures of health seem to decline. So it's hard to know how to interpret that. I would say it's mixed evidence. Here's a study in Kenya. So in a lot of contrast to the situation with nuts, when you're talking about treatment, they didn't find as much price elasticity. Okay, again, that's consistent with the behavioral economic story. If you've got malaria today, you feel terrible. you want to get that medicine and feel better. It's not, well, if I take this, I might be less likely to get sick later on, but that's uncertain and hard to pick up and event that happens in the future. Okay? I think there's a lot of room for further research in this. Here's a program in Mexico. This was a program sort of branded as an insurance program. I don't know as much about it as I should, but it's also just reduces the price, effectively, of care for people. And you saw that this, from a consumption smoothing point of view, maybe this is very nice. It led to catastrophic health expenditure went down. But you didn't see, at least in the short run, an impact on health outcomes, or even on healthcare utilization. Yeah.
So one big problem with a lot of these studies is they tend to focus on the public sector, whereas something like 90% of those out-of-pocket expenditures on health are actually going to the private sector, which
Right.
goes back to your convenience and being sensitive.
Right.
So I think it's very difficult. I mean, and people are pluralists. They go to more than one
Yep.
place.
Yep.
So there's a real issue with trying to design the studies in ways that you actually understand. I mean, you have to do a lot more qualitative work to figure out what happened in every single case, which is very expensive and very difficult to model.
Right.
So anyway, I mean, I don't know every single one of these studies, but the first three in that Mexico one, I mean,
So
some
I'll
issues with the not taking a systems view.
Sure. I as a general point, I keep saying this, but I hope it'll turn out to be true. It's a classic thing for speakers to say, "Oh, it's going to come in a few slides," but it really will. But call me on it if it doesn't. But I will talk. When I turn to the sort of health system side of this, I'll talk a bit about the private provider side, which is very important in lots of places. I think in a certain way, it makes the fact that you didn't see an effect on healthcare utilization all the more paradoxical, because you would think if the price goes down a lot, you should see an increase in treatment. If you're not, increase in utilization. If you're not, maybe that says the consumer, they really don't like this public sector. And I think there's reasons. I don't know about Mexico in particular. It might be very different. But certainly some other countries that I know better, there might be reasons to not like the public sector.
That's a study that had 6 months of
Yes.
implementation experience, so.
Yeah, it's a little bit early.
Yeah, and there's other studies that are actually better now on delivery care and outcomes of birth and things
And
like that.
they're starting to find
show
impacts. Oh,
effects.
that's great to hear. That's great to hear. I was surprised, quite surprised to see so limited impact. I think this is an area where we really need a lot more work. I think this is, in some ways, what we talked about in the first half was the low-hanging fruit and relevant for the very poorest countries. But as you get into middle-income countries, this is going to be very important, and even in poor countries. The other puzzle is there's very low take-up of voluntary insurance programs. So MFIs in India have tried to put in health insurance system. There's not a lot of demand for it. And even when people get the voluntary health insurance, there's often very low take-up. So the RSBY program in India, for example, has surprisingly low usage rates. Let me click on a bit and talk about so this is still about consumer behavior, but let me turn to the healthcare supply. And
Are you talking about voluntary health insurance just over the poor or across the population as a whole? Because in India, I thought it was actually quite high uptake.
So I'm talking about among the poor. It might be that in formal sector things there's take up of it, but is it voluntary? Is it truly voluntary there?
Yeah, it's private sector health insurance for people who can afford to pay the premiums.
Okay. Well, so let me say one thing on this. Oh, it's okay. No, these are very helpful comments. Let me actually draw a distinction, which I think is a very important one. When I'm arguing that there's big reductions in demand, I'm not necessarily arguing there's reductions in demand all the way to zero. And there's an important distinction, because if you're a private company, or an NGO for that matter, and by having a system where you're charging, you can get 5% of the market, or 10% of the market, or 30% of the market. That's great. If Coke wants more than 30% of the market, but there are plenty of companies that have a very good business with 20% of the market. And so but from a public health perspective, you typically won't be satisfied with that. So I don't want to claim that there's no role for these things. Yes?
Just before you leave the consumer
Yeah.
behavior, are there any ways to stratify this analysis to see whether the price elasticity is a function of household income? Because it seems like 30 cents is relatively more or less for different levels of income.
So I don't know the answer for sure to that, but let me give you my impression. I think, so excluding most of these studies are done in rural low-income settings. So I'm excluding sort of the formal sector, urban people. So let's say I'm excluding the top 10% of the population. Within that bottom 90%, my impression is there's surprisingly little correlation with indicators of income. That might be because we've got bad indicators of income, but it's not. Again, the simplest health investment model would tell you, oh, there'll be a cutoff level of income. Everybody below that won't purchase. Everybody above will. I mean, that would be a very simple model, but you get surprisingly little of that. I think has much more. My sense is it has much more to do with, is it, one of the reasons why people don't pay these small amounts is it's inconvenient, they don't get around to it, it's a little bit of decision cost, you have to think about it, and that can be a barrier even if you're not the ultra poor. So I think empirically there's less correlation with income than within the bottom 90% than you might expect.
One of the problems in rural areas is you have less variation.
That's right. That's right. Yeah. I think that's true. Yeah.
What about variation across the tangibility of the benefit? I mean, that's, right, so you talked about antimalarial versus mednet. It seems to me that if it's preventive and you can't clearly link an intervention to a benefit, you're going to have a very low willingness to pay.
I think
whatever your income level.
I think the prevention versus treatment is a big and very important axis. There might be other ones as well, but I think that is a very important one. And the tangibility, I think, is another. Okay, so let me say a little bit about healthcare supply. So let me start out with a little bit of background. So this isn't randomized evaluations. It's just information for those who aren't familiar with the field. So there's both the public sector and the private sector are typically very important. So the public providers often have, and they each have sort of show the worst stereotypes of their sector. So the negative stereotype of the public sector is very weak incentives, et cetera, and you've got that in spades. High absence rates. These are the absence rates among healthcare providers and teachers in a 6-country survey. You can see that it's very high, 40% in these low-income countries. The middle-income countries have somewhat less of a problem. Worse problem among health providers than among teachers.
And worse for doctors than nurses.
Yep, you bet. The higher ranking you are, the more likely you are to be absent. The service quality is terrible. So let me see if I have the statistics. So North India, the physicians spent 3.8 minutes per patient. They asked 3.2 questions. They prescribed 2.63 medications. Okay, so just get them out of there. Okay, and some places, I think this varies by country, but they're unofficial. Even if the service is supposed to be free, they charge unofficial fees. So very poor quality, and you hear lots of horror stories of really terrible treatment, patients being beaten and so on. The private providers have stronger incentives. They're on fee-for-service typically, and they want these customers coming back. But the incentives are often misdirected. So there's, in terms of technical categories of economics, there's asymmetric information. The patients don't know necessarily what the right treatment is or what their qualifications are. They know. And there's a weak regulation system. So you get many unqualified providers in some countries. Involved in a study in India right now, the vast majority of treatment is by private providers for poor people. And many of them, the majority of them they don't have medical training. And it's not that they're traditional healers. They're doing, they may have a degree in that, but usually they have no health education. But if they're educated in Ayurvedic medicine, they're still prescribing the antibiotics. So you also get things, just unqualified providers or people doing things that make you feel better in the short run, but don't help you in the long run. So that could be a sugar pill or something, but it could also be steroids. Okay, that really makes you worse off in the long run. That's, we academics may only be figuring out about behavioral economics and present bias, but these quacks figured it out a long time ago that this is a good strategy. So they also have few incentives to take into account externalities, to give vaccines and things like that. So you have this combination of really the worst of both worlds. And I think this is really trying to figure out how do we address this problem is a big part of the challenge going forward. Okay? What are some approaches? Well, with all this absence, one approach is to pay for provider presence. So there's a study in India that said, okay, we're going to try to pay the nurses based on their attendance. And there were pay deductions if you didn't show up. Okay, so at first this seemed to work. They responded to the incentives. But in the end, the system broke down. Okay, the nurses would break the time clocks. The administrators would say, oh, it's an excused absence. Within 16 months, the program had no impact anymore. Okay? So there's that's why one of the analytic frameworks that I put up, where I don't have many results yet, but to report, certainly none of my own, is political economy. I guess I do have some political economy in education, but not in health. But I guess this,
This study is very unusual because it lasted 16 months.
Yeah.
A lot of the benefits you've reported from other studies, your deworming study, trying to slide, are reported over very short time frames where you don't have time for example, the supply side to adjust.
Right. So certainly, there's another reason why they often don't get supply side, because they're demand interventions at the level of the household, not going necessarily through the normal supply side. So I think there's a bunch of issues. We know a lot more about the demand side than we know about the supply side. And if you're thinking about a general scalp of a program, you do need to think about how the supply side will work. So I completely agree with that. And this is an area where more research is needed. But another implication is if you can structure delivery channels, it doesn't have to be through the broken healthcare system always. It can be through other channels. So if you're thinking about, and I'm not saying something I'm not allowed to, but I'm more sympathetic to vertical campaigns in some cases, if you can get a system that's actually delivering things. And there's no particular, deworming, take that example, that can be delivered through the schools. The absence rates are lower at the schools. You've got 8 teachers there. The school's usually going to be open even if one of them is absent. So thinking about other ways to deliver health through systems that are functioning better can be useful. You're not going to be able to give TB treatment that way or deal with broken arms, so you still have to fix the system. This thing didn't seem to work. Let me put up a couple of other things which are somewhat more promising. I don't want to argue this isn't promising. It's just it would work if it was enforced, but there wasn't a political will to keep it going. Here's an Indonesian program which said they gave block grants to communities. They said that they would, in some cases they said they're going to tie the grant to results at how well the community is doing. They saw various process measures improve. They did more likely to do weight checks for children, iron tablets for pregnant women. Malnutrition then went down 2.2%. So this suggests that performance incentives were quite effective. Okay? There's a study in Rwanda which also found very positive effects from a pay-for-performance program. I don't know whether to count it as a randomized study because there were some changes happened in between. They had to use other techniques in the end, but I wanted to at least mention it. Okay? Here's another strategy, which is trying to let's empower the community. If the patients, right, if the doctors aren't showing up, when they do show up, they're spending a tiny amount of time per patient, then maybe the community can do something about it. So there's a program in Uganda which tried to do this. And they organized the community to do it. It was very successful. Absenteeism went down. Vaccination rates went up. More children got vitamin A. I believe they also saw, maybe my memory is failing me, but I think they also found big health improvements as well. So that suggests if you can find reforms that make providers more accountable, not from top down, we're going to dock your pay, but from below, that could also work. But that said, let me put a caveat here, which is Uganda already had a program in place which was supposed to be doing this. So this program worked, but it suggests that it might be a hard thing to do if their existing program wasn't already working. So, I would say both this and the top-down approach would work. Looks like they could work if done well, but doing them well is going to be a challenge. Okay? Here's another example. This is something I was involved in evaluating. I would say the same thing about it. It worked. Figuring out how to do it well is going to be is a challenge. So Cambodia had a very weak healthcare system after, in the late 1990s, Pol Pot killed all but 50 doctors in the country. They tried contracting out the management of healthcare on a district-by-district basis. Other organizations could bid, but it was NGOs that won the contracts. And the NGOs would bid to manage the government healthcare system, basically. And they would typically, they got contracts where they would be rewarded for achieving outcomes. And those were typically things related to prevention or cheap treatment. We saw a big improvement. This is health. That's not accurate. On healthcare delivery in the contracting districts. So the targeted outcomes increased by a lot. Kids were more likely to get vitamin A, get prenatal coverage. There was better healthcare management. Absence rates went down, et cetera. Medical supply availability went up. It was a tiny number of districts, so you don't have statistical power on actual health improvement. In fact, I was surprised. It was only because the effects were so big that we saw this. The population responded. They went more often to government facilities and went much less to traditional healers. This is traditional healers, more generally non-qualified, non-biomedically qualified practitioners. There was an increase in spending with this, so I don't want to claim this was purely a management change, but there was a decrease in private health spending. So those things, overall health spending probably didn't change very much. I don't know why that is not a correct, that last bullet point is not correct. We don't know. So let me conclude and then take questions. So I think there's a lot of low-hanging fruit out there. I want just to return to the first part of the talk. I think we've learned a lot about consumer behavior around preventative health measures. There's a lot of things that we know from medical evidence are very effective that are not being used. And or I don't say they're not being used. There's a large proportion of the world that's still not using them. And we've seen a lot of improvements in some parts of the world. Recently, we've seen a lot of improvements even in the parts of the world that had been lagging behind. But there's a lot more we could do on this. And I think it's really a matter of actually implementing this. Okay? I think there's a lot less we know. I quoted some promising studies, but we know less. The current state of health systems is very weak, both the public and the private system. We know less about how to improve these things. Both on the issue of reform to get better quality and on the issue of healthcare financing and insurance. In each case, I think there's a political economy challenge, which is both understanding what is the politics of this and thinking about how to change it. One thing I want to put out to be provocative is maybe there's a role for a rights-based approach for both of these. And we know a bunch of things that would improve health a lot. And if we think, let me turn to the water example. I think there's very arguably, if there's a 3-year-old who's drinking fecally contaminated water and is dying from that, and that's something that can be very cheaply addressed, I think that's a human rights issue, and there's a case to be made for saying that the government of the country or international donors should come up with the funds for that. And then on this issue of healthcare systems, I would say that's also a exploitation issue and a rights issue. If there's a doctor or a nurse who's earning a formal sector salary and they're not showing up to do their work, or they're spending 2 minutes with the patient and giving them the wrong treatment, and just one work that I'm involved in now with colleagues at the World Bank suggests that if you look at the performance of, we looked at arranged for standardized patients, actors, to go in to clinics and see what treatment they got. They got the best treatment, the worst treatment they got was from the government doctors in the government clinics. And these were fully qualified doctors. They actually got better treatment more or less, from the unqualified practitioners who would spend more time with them and who, despite the lack of formal training, didn't put in some effort and managed to do better treatment. They got the best training when they went to the government doctors operating in their private clinics. So, that gap between how the government doctors are performing in their public role and in their private role is, I think, when they're being paid by the public sector, is a rights issue. I think we've learned a lot. There's a lot more to learn.
Okay.
Thanks.
Thanks very much, Michael. So we have 15 minutes for questions. Mead, and then let's collect 3 questions. Mead on the end in a green shirt. Oren, and the back. Okay, go ahead, Mead.
So,
Please be concise and say your name.
2 things. My name is Mead Over. I'm a senior fellow here at the CGD. There is some evidence that increasing or allowing user fees or reinstating them, especially after they've been abolished, actually improves the efficiency of the supply side of the healthcare system. And that evidence comes from, for example, Madagascar and Uganda, I'm aware of. So isn't it possible that all the advantages of free care and even of subsidized care that you argue for on the demand side might be more than overbalanced by the extraordinary benefits of user fees to actually make the system function? So that's my first one. And then on the rights thing, I want to recount the experience that we had when we were trying to measure how much absenteeism or how hard the providers were working. We found that the IRB, the Board of Ethics at the universities in the United States, would not allow us to ask those questions because it would be an infringement of the rights of the provider to actually find out they were doing a bad job. So when you're talking about rights, you get into where you might find the rights of the providers, because of their much better lobbying power, end up dominating the rights of the consumers.
Okay, Oren. Sorry.
Great presentation. I'm Oren Levine. I'm a third day visiting fellow here. It's a great presentation. I learned a lot. The first comment is just, I think there's probably more to explore in the demand side stuff in terms of interactions between individual characteristics, like how much household income they have, how much education they have, and maybe for some of the child health things, whether they've had a child before or not. Because those might, and it might be not just a one-size-fits-all, but actually if we figure out certain demographics, and of course the urban stuff is another issue, since a lot of the data are from rural areas. My question was whether there's any data. You showed a lot of price sensitivity and how individuals respond. Can we do this kind of stuff with governments and see how governments respond, and whether they are any more or less rational than we are as individuals?
I'm Catherine. Speaking to the microphone. Sorry. Sorry about that. I'm Catherine with the Dispensers Project, and I was actually wondering, so you talked about how there's no sensitivity, so no better targeting of chlorine product to families with children when there's a price charged. When there's no price, we actually do see targeting, that families with children under 5 are more likely to use the product. So do you see that with other interventions? When there's no price, do you see natural targeting to those that are benefiting the most? And I guess sort of the second question, sorry, I forgot. Oh, I forgot, sorry. Thanks.
Can I take one more, because I saw Michael? Yeah. Michael always asks interesting questions.
Sure.
Michael Clemens.
No pressure.
Michael.
But speak into the microphone and say something.
Michael, one of the most compelling RCT results I've ever seen is Karthik Muralidharan's contract teachers work that I'm sure you're familiar with across the entire state of Andhra Pradesh, the size of Germany. He with subtleties, randomly substituted civil servant teachers with contract teachers, making 1/5 as much money, and the students learned exactly the same amount. Just a stunning, very interesting. And then the guy with the office right behind you, Justin Sandifer, has an experiment in Kenya that I'm sure you're also familiar with, in which he implemented a similar intervention through the government and through an NGO and got dramatically different results. This seems to suggest an entire research agenda that seems to be more developed in education than in health. The work you referred to right at the end, I didn't know about, and I'm wondering if you know of related work in the health area. It seems very fruitful to me.
Okay, we're going to let you respond, but I just want to say there's a whole trust fund at the World Bank that's piloting results-based funding approaches on the supply side with very rigorous evaluation designs.
So let me respond to Mead's question about could there be a supply-side impact of user fees that could be beneficial?
Sufficiently beneficial to
and could even be sufficiently beneficial to overcome the costs on the demand side. I think this is an area where it really makes sense to think more broadly, in my view. I think we now have documented costs on the demand side. It's quite plausible. I'm very open-minded about what the impact is on the supply side, but I think it's worth thinking about. It's a very separate issue of how you pay for something and how you implement it. So let me give two examples. Let's take the Cambodia healthcare program. So the health contracting program. The government, and ultimately the donors were a big part of this, were paying for the healthcare. But the operation of it was contracted out to private agencies which were competing for it. That gave them better incentives. Now, I don't know I don't think their incentives were explicitly linked to the number of patients, but take what to Americans is the paragon of socialized medicine, the NHS. Well, the way the NHS works, the government's paying for things, but the general practitioners are paid not a flat salary the way they would be in India or Uganda or any of these places. In this sort of paragon of socialism, they're private contractors, and they're paid based on how many patients they have signed up. And if the general practitioner treats their patients badly, well, the patients will sign up with another general practitioner. So I think that there are ways where you can achieve the benefits on the demand side, while still, clearly we have very bad incentives on the supply side. And I would argue both in the private sector and in the public sector, but clearly in the public sector. They're worse in the public sector. So we got to address that problem. I think that there are probably creative ways to do that don't involve necessarily charging the patient for that class of things, and I'm not saying it's everything, but certainly preventative things against communicable disease that we know are cost effective. That I don't think it makes sense to charge the patient for. We got to find a better way to incentivize the providers. I agree with interactions are an important issue to look at. I think this point that not only do you not get targeting when you charge, but at least in the case of chlorine, you get better targeting when you don't charge is an interesting one. I don't know how general that is. I think on the issue of contract teachers being extremely successful, so I think that's a very interesting approach, and community health workers would in some ways be the analog of that, and I think that's a very promising area to think about. But your second point on that was that how does it work in practice depends on how it's implemented. And I think that's got to be true. It can't be, it can't be that if you just have a program on paper and you don't implement, if it doesn't happen on the ground because of failures in implementation, people don't get paid, or the payments are delayed, which I know is an issue in one of the arms of Justin's in the government arm of the thing that Justin looked at. Then you're not going to get the results. And so figuring out the details of it, clearly the details of implementation for any of these things are going to be very important if you try to scale it up.
But is there a community health worker RCT? I think it doesn't exist. Is that right?
I'm not aware of it. It may exist. Nava Ashraf is doing very interesting work on this. So I think there wasn't when I wrote this, and there is now. So.
I mean, there have been, not RCTs, but there have been experiences of contract doctors or health providers versus salaried health providers, or there's different ways to pay them. So, I mean, there has been quite a bit of experimentation on that, not all of it in low and middle income countries.
Right.
I think that's a really big issue.
There
But-
was a big ADB
Yeah.
project for urban areas in Bangladesh,
Mhm.
municipalities, and they didn't find that much of success because you have more choice with healthcare, and the entry level, the price entry is much lower, whereas for schools, you have to enroll for a semester or a year, and you have much less choice in terms of where you go to get your education than you do to get some drugs or a diagnostic test. So the contracting issue and, comparing a contracted person with a government civil servant person and what they can deliver becomes much more complicated, I think, with health than with education. There was a question about looking at government's behavior, and that's where the design issues come into, you can't have an RCT on that, can you?
No, you can't have an
So-
RCT. I'm just wondering if even through observational stuff, you can figure out whether.
Right. So you have to have people who are
Well-
okay with the observational data.
Well, let me,
Use the
there's,
microphone.
there's the Generosity program, the program in Indonesia. So Ben Olken has a study of that, which is an experiment with local governments. Indonesia's big enough that they are doing randomized evaluations with local governments, and they found the local governments were responsive. That's actually another thing I think is very interesting in terms of how to reform systems. I think maybe decentralization with accountability, if you just decentralize without accountability, it's not going to do anything, but the right type of decentralization might be another route to explore.
Okay, we have 10 more minutes. I wanted to ask you a little bit about, the RCTs are, can you talk a little bit about using RCT evidence in policy? Of course, you gave the example of chlorine, but, we like to use this term proven, effective now for there are certain kinds of delivery strategies. This issue around the use of, the work of IPA, for example, around the price of certain health products, which is, in the end, 5 studies in certain contexts, is generalized by, in policy by saying no user fee for anything, no copay for anything. There's a certain group of people who believe that and are acting on that. There are others who have a more nuanced view. So, can you talk a little bit about things policymakers should think about when they're looking at RCT evidence? And of course, you should act on what works, but,
Sure. Let me discuss that. So let me give a micro answer to that, and then go to the larger issues. So I think there are some cases where this is influencing policy. Chlorine is actually probably pretty early. There's in that process. But the thing that's by far the furthest in that process is conditional cash transfers. This is a program that is not that old a program that was done in Mexico. It's now in 30 countries, and I don't want to claim only because of the evidence, but because of the combination of very rigorous evidence and then a lot of work by policymakers in Mexico, by Santiago Levy, who deserves immense credit for this, by the Inter-American Development Bank, the World Bank. That's now in 30 countries, and that's reaching. This is a huge innovation in development policy, and that's really scaled. So that's a clear example. And I think what you think of that depends on your attitudes towards redistribution. I'm sufficiently pro-redistribution in Mexico or Brazil that I'm a fan. The deworming is another example, not as far along, but in part based on this evidence, and I do think it played a role. Kenya scaled this up to reach 3.5 million kids. They then ran into, it was part of their general education sector strategy. They had a corruption scandal in another part of their education program, and the donors cut off funds, so it was put on hold, but it's now being relaunched. So that's a case. And then once Kenya did it, Bihar did it, Delhi did it. So I think there's, that's earlier on the, and there had been other programs as well. So I don't want to put all the, give all the credit to evidence on that, or even the evidence plus the work. One thing but there are a lot of examples that haven't been scaled up. So I think one thing that's very clear is a lot of work, and this comes back to Michael's question. A lot of work is needed to figure out how to take something that worked at a small scale and to try and do it at a larger scale. And that's going to require a lot of thinking about implementation, about costs, about how do you work within the rules of bureaucracies. It's a lot of work. And then it requires further testing to make sure it's still working as you expand it. And maybe that's with a randomized trial, maybe it's not with a randomized trial, and using other techniques. I'm not talking here in my CGD and Harvard capacity, but I'm also doing some work with USAID, with a new group there called Development Innovation Ventures, which is designed to try to support things, new ideas in development, from the idea phase to the rigorous testing phase, through the phase of transitioning to scale. So look us up on the web if you've got an idea, if there's something that you think worked, whether it's early stage or whether it's at this stage of saying there's something that came out of a randomized trial, let's try and take it to the next stage. We welcome applications on that. And the rules are on the web. But you asked another question, which is, are people going to, how do you interpret all this evidence? And look, on an issue like user fees, this is a super ideological issue. There are going to be people who long before there was any of this evidence, there were a lot of people who were very pro-user fee, a lot of people are very anti-user fee. I think there was a lot of beliefs. People were making a lot of claims as part of those arguments that were empirical claims, and turned out that they didn't match, all of the facts. And I think the randomized trials have shed some light on that set of facts. There's still legitimate reasons. If you're a human rights-oriented person, you'd be against user fees no matter what, almost no matter what the empirical evidence. If you have very strong beliefs about the supply side and about the feasibility of this alternative strategy, I said, you might say, look, I know all that evidence is there on the demand side, I still don't want to do it. But I think, producing the evidence helps inform the debate, and there's going to be a group of people for whom this will be useful. And it also suggests that we might, and I think this is a point I'd really like to push, it suggests that we might come up with new strategies that get around some of the, that try and achieve multiple objectives. And, in my answer to Mead's question, I think let's try and find ways to improve incentives on the supply side, in this particular example, that still get access to preventative treatments against communicable disease on the demand side.
No. Sorry.
Okay.
First, thank you so much, Michael, and thanks to everyone for coming.